Hey Doc, can you hear me?
Yeah, I can. Good morning, Paul.
Hey, good to see you.
Good to see you too. Well, actually, let's see you. Can you turn on your camera for a second?
Yeah, I guess I thought it was on. Um, 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 um.
Towards the bottom left-hand side of your screen, there should be something that says start camera or start video.
It does not give me that option, Doc.
All right, try it now.
You got
Hey,
me?
there you are.
Hey, it's kind of bright here. We've got a foot of snow outside and it's just,
You look like that scene in the movie Ghost with Patrick Swayze and Demi Moore.
Where,
You're
where's the,
glowing.
where's the penny up the wall?
Yes. All the good stuff, not the evil spirits, but you are definitely looking like the ghost of Christmas past or something here.
Let me see if
Um,
let me see if I can do something with that.
all right.
Uh, is
Oh, that's
that it?
better.
Is that better?
Yeah. Is that your place?
Yeah.
It's
Yeah.
beautiful. Do you mind everybody being able to see it? I mean, I think it's a
No,
lovely backdrop.
fine with me.
Wow. Looks like you guys have a loft up there.
Yeah, it's a Yankee barn home. So it was built out of old repurposed barn timbers from up in New Hampshire and Maine, and that are
Oh,
100 and 200-year-old barns, and they take them down and they bring the timbers and they build the house. So
amazing. How special.
we got a doctor owned the place, so we got a pretty good deal on it. We didn't build it, but we're sure happy with it.
That's awesome. I think I saw Paul in the background too.
Yeah, Karen's trying to corral everybody just in case. We've had a lot of deer running around lately. I bet we had 60 deer in the yard last night.
Wow,
Uh,
that is a
because
lot.
they're digging up stuff in the ground because there's a foot of snow on the ground.
Mhm.
So you got them, babe? So she corralled them all upstairs. So
Oh, okay. I may have to corral mine. He's being sweet right now, but you know how that goes.
yeah. Oh, hang on. I'm trying to find a way to video filter. Maybe
While
I
you're doing
can,
that, I'm gonna pull up my slides.
yeah.
Let's see. Where would it be view? I think. Here we go. Can you see that, Paul?
Stand by. Yes, I sure can.
Awesome. Okay.
Is it okay if I wear the Stella shirt? I mean, is that good? Okay, cool.
Synced up, tracking.
Yeah,
Yes.
we're synced.
We look like a team here.
My wife and I are always on the same page, and we're always looking at each other. She'll come walking in with something like a glass of tea, and I'll be just about to go, can I get a glass of, and I'll be like, get out of my mind.
I have a glass of tea that I just brewed for this, actually. uh, I'm doing
Hey,
a little jasmine tea today.
nice. Jazz up this day. I don't know if you knew, but last week I went to a warrior retreat in Texas, called the Mighty Oaks.
Oh yeah, I know that one. Is that Chad Robichaux, right?
Yep. So
Yeah, yeah.
Blake asked me to go ahead and go. We had some guys interested, and he goes, I really don't have a point, man. Are you interested in going? Can you break away and just kind of come back and give us some feedback? And I was like, sure. And it was a very faith-based retreat. I kind of like, if I kind of, Karen and I kind of balanced how do I feel after I came back versus, before I went. And I think we're both of an agreement that I actually feel better after the warrior connection than I did coming back from the Mighty Oaks.
Interesting. Well, let's talk more about that offline, but
Sure.
I've heard good things about, I think very highly of the Warrior Connection, and it's because of, my friendship and relationship with Aaron that I trust what, that retreat does. I've heard good things about Mighty Oaks too. I have also heard that it's very faith-based. And so I think it's important for people to just know what they're getting into. I have a collaboration with my friend Jennifer Tracy, and she's going to start doing some faith-based offerings, and I'm happy to have her do that. I just said, just make sure people know that, it is what it is, so they can select into the stuff, I've developed that it doesn't tend to be faith-based versus what, she might offer that is. So anyway, we can talk more about that offline, but
Yeah, no worries. I knew what it was going in, and I'm glad I went, and I had a great time. So
awesome.
thumbs up all around.
Awesome. All right. Well, I am going to see who we have here. I actually can't see while I'm in screen sharing mode, so I'm going to go out of that for just a second. And I know that we had a few people come in. Let's see. So we have a few people here. I see Teresa. Hi, Teresa. Teresa, I don't know why this is, but you're showing up 3 times in here. Just FYSA. Erica, good morning. And Cam, good morning. And good morning, Lori. I see you in here. Ah, okay. Gotcha. Give it a couple more minutes, Paul, if that's okay, and then we'll jump in. So is that real stone behind you? I just have to ask, in that column?
Yeah, it's actually the south side of a great room fireplace. It's a gigantic fireplace. So
Oh,
yeah, it's pretty cool.
cool. Kind of like a lodge feel.
It
That
is.
is such a special place. Wow.
It's quiet. 30 acres and dead end road and back up to a river, and
I want to come visit someday. And
you're more than welcome.
that would be so much fun. You guys have a beautiful space, a beautiful corner of the world. How far are you from like Chicago-ish?
Oh, a couple hours.
Okay. Okay.
I get accused of being an isolationist, but when I come here and when I'm home and it's so quiet and peaceful and everything, I just really don't want to go out and mess it up. So
Oh, your space is beautiful. Yeah.
Thanks.
You're not like a survivalist where you're like roughing it.
No, we're not prepping here. We're just enjoying life, quiet life.
Yeah. Oh, it's great. All right. Well, let's go ahead and get started. Now, this it's automatically recorded. So what we'll do is we'll just cut it later. To start at 12:07. All right, well, welcome everyone who is here. I'm going to go ahead and get started. This is our Stella Trauma Treatment Approach monthly webinar. I'm here with Paul Whitmer, who is one of our Stella ambassadors, a patient that we have treated, and also an Army veteran and a friend of mine. And he's going to be doing this with me every month, and we'll be sharing his story toward the end of a little information that I will share. Dr. Shauna Springer, Chief Psychologist for Stella. And this mission matters to me because of people like Paul, because this isn't just theoretical when I think about the impact of trauma on those who support and protect us, but also the wide range of people in the society in general that have been impacted by trauma. I think most of us have had some kind of trauma impact, especially after the last 2 years. And Stella's mission is to relentlessly be driven to innovate in support of those who suffer from trauma symptoms. So just a few, statistics and figures that PTSD is a universal human crisis. I'm not somebody who tends to exaggerate. I don't use a lot of big words like crisis. I'm a trauma psychologist, so I'm probably numbed out somewhat to crisis, but PTSD is absolutely a universal human crisis. These figures were generally pulled before the last 2 years. So when I talk about 8 million Americans suffer each year from trauma symptoms, that was before we had a global pandemic, racial division, political divisions, so many of the natural disasters, fires, floods, and things that we've had in the past 2 years. So even so, these numbers are really staggering. And, to give a specific example of one of the impacts, there have been over 4,400,000 deaths in relation to COVID-19. And research shows that between about 20% to about a third of people who have had COVID in the post-illness phase experience symptoms of post-traumatic stress. This generally is people that have been hospitalized for COVID symptoms, to be clear. So not just, anyone who gets Omicron necessarily, but people who have really gotten this and had a moment of reckoning with, are they going to live or not, their own mortality. So almost a third of those people have had post-traumatic stress symptoms in the post-illness phase. And similarly, in the past 2 years, domestic violence calls have increased by 10 to 27%. And this was really peaking between March and April of 2020, when the shelter-in-place orders took effect, when people across the country were in a sort of helpless, frustrated situation where many were losing business and jobs. They had invested many years to grow and create, and they were at home all of a sudden without income, with massive stress from financial stress, the changes in the world, being sequestered in their homes, and the domestic violence calls went up dramatically during this time period and have been up since then, although not as much as during this time period. And we'd love to get everybody treated that has trauma, but there's a lot of barriers in the way that the field of behavioral health and medicine approaches trauma. And traditionally, I would say that it's really been seen as in the lane of behavioral health, to include psychologists, psychiatrists, mental health counselors, therapists, licensed social workers, all with hopefully a trauma-informed focus. That is where treatment has occurred primarily. And there are many barriers to the current model, mental health stigma, the feeling of being singled out or being made to feel like you have a condition that is, different from most people, or that you're broken in some way that's hard to put into words. Many people, veterans and civilians alike, may be reluctant to seek help after a trauma exposure if they feel that they are going to have to share details of the worst day of their life. Even with a licensed professional, that can be a deterrent to care for many of them. Many of the frontline therapies that involve exposure protocols will cause an increase in symptoms before things get better. That can be a barrier to care. Many people don't want to be on medications. Medications are optional and can be helpful, but there are many people who say that's a no-go for me. I'm not interested in medications. I'm concerned about any long-term impacts on my body, and they won't take medications. So concerns about receiving a diagnosis, dropping out from care. Do I have the time to fit a lengthy course of treatment therapy into my life with my job, my kids, with all the other responsibilities I have? And then the cost of traditional treatment. Even with insurance companies, many times it adds up. And it's not just the cost of the treatment, it's the cost of gas, getting to and from appointments. It's the cost of the time it takes to get treated. So these are some of the current barriers to the care model that exists right now. And SGB offers a new treatment pathway that I believe should set a new standard for care. Not just SGB, to be clear, but SGB, ketamine, and other biological treatments, when used in combination with traditional talk therapies and trauma-focused treatments, is a game-changing strategy for helping people with trauma. And so, although trauma has been seen as being in the lane of behavioral health and its providers and clinicians, out of the pain discipline, the people who treat pain, the physicians who do nerve blocks and injections for pain, comes this really interesting discovery from the chief medical officer, Dr. Eugene Lipov of Stella. And I think Dr. Lipov treated you, right, Paul, if I'm remembering correctly?
Sorry, I had to unmute. Yes, you are correct. It was Dr. Lipov.
You saw Dr. Lipov, who published the first case report in 2008 to look at this new procedure for treating trauma symptoms. And I'll tell you what it is in just a second, but it's basically founded on the concept that trauma is not mysterious or invisible. It's been called an invisible injury or invisible wound of war. But it's not just a wound of war. It's a wound that many people across society have from many causes: sexual assault, domestic violence, the things that we do to each other that cause lasting damage, not just in the war zone. But that it's not mysterious or invisible, and it actually causes a biological injury that's maintained by how we think and behave. Changes in how we see ourselves, how we relate to those in our lives are all part of trauma, but it is in part a biological injury, and something changes in our system, in our biological system, that can be addressed and healed. And so SGB is an injection in the cluster of nerves in the neck called the Stellate Ganglion Block, right about here where I'm pointing on my neck, a few inches above the collarbone. And it is associated with the fight or flight system. So many people who have trauma exposure get kind of locked into a constant state of threat response. Where is the threat coming? How can I respond to protect myself? They're in sort of this chronic protective defensive mode. And SGB targets the hyperreactivity of those kinds of trauma exposures. So symptoms like difficulty sleeping, being flooded with anxiety or panic, having difficulties concentrating, that startle response where you jump out of your skin if someone walks up behind you, the hypervigilance of really looking for the threat from every corner, sitting with your back to the wall, not feeling safe really in any environment. And as well, irritability and anger can be a large part of this hyper arousal set of symptoms. So SGB seems to reboot the system and return the body to a state of calm. And it works in most cases, not all, but I will present that outcome data here a little bit later. So here's a graphic to show where the injection is placed. What is injected is not psychoactive. This is important because people sometimes put SGB or stellate ganglion block in the category of psychedelics, and it's actually quite a different thing. It's an anesthetic medication that is injected. So there's nothing in here that will make you euphoric. Some people, it's interesting, do describe a feeling of being, quote, high after the procedure, but that's not anything physiological. It's simply the shift of being so tense and so coiled up to getting that, finally, that release from all of that pressure and trauma that can make people feel very light and happy and joyful. And it can restore people to a range of natural human emotions, feeling warm and loving feelings for those close to you. And that kind of dopamine connection can make you feel bonded and sort of euphoric, but not because the medication does anything directly to produce a feeling of being high. That's been coming up in some of the organic videos that our patients have been posting on LinkedIn. And, while I love those videos, I'm always going to use opportunities to educate people about what is true about this. And it's actually just an anesthetic medication. So like, think about Novocaine at the dentist. When that's injected, it doesn't make you high, but it prevents a lot of pain, when you're at the dentist. It's the same kind of anesthetic medication that's injected here, typically ropivacaine or bupivacaine in this case. And stellate ganglion block is not new. It's actually something that's been around for about 100 years, since 1926, when it was first documented in the medical literature. And again, originally developed as a pain condition used by pain providers. So the physicians who do injections for nerve blocks and things like that, for conditions like shingles and phantom limb pain and complex regional pain syndrome. And then in 2008, it was published by Dr. Eugene Lipov in that case study. And since then, there's really been a proliferation of excellent research and practice around using this for post-traumatic stress symptoms. There's also something called the Treat PTSD Act that we want people to be aware of. This is HR 1656, if you want to look it up. And there's some political momentum behind requiring the VA and the DoD to provide stellate ganglion block to veterans and members of the armed forces who have been diagnosed with PTSD. It requires that the VA and the DoD update clinical practice guidelines. Think of this as kind of the standard of care. So it's saying, hey, this can be a great treatment as far as a high quality standard of care for treating those who have trauma, not as a last resort or what you might try when nothing else works, but as something that might actually really help people as part of their treatment plan. And HR 1656 has been endorsed by the VFW, AMVETS, and the American Legion. I'm sure there are more people since I last worked on this slide, but at the last time I did this slide, there were 22 bipartisan co-sponsors in Congress, and I should probably update that because I'm sure there are more at this point. So here are some key points in the history of SGB. I talked about how it was first documented in 1926. As early as 1947, it was documented to have potential impact on depressive symptoms. And it had a little promise in this one study. But then what happened was the pharmaceutical machine, the engine of medications, really kind of came into play right around that time. Prozac was released and it was shown to be effective, and that field took off in terms of treatment for depression. And I will say right now, I'm not anti-medication. I've worked with an excellent depression clinical and research program at Mass General Hospital, some of the best. And I can tell you that depression medications can be life-changing and life-saving for some people. So I'm not anti-medication whatsoever, but I think perhaps if there were potentials for SGB to target depression, like I'm sometimes seeing in some of my case studies, just informally, it never really got tested. So that's kind of an untested question to be determined in the future. I mentioned Dr. Lipov publishing about his first case study was actually the victim of an armed robbery who was going to be put into an inpatient treatment program because his symptoms were so bad. And he kind of made like a last ditch stopover in Dr. Lipov's clinic, and nobody really knew, but Dr. Lipov had theories about why it might help him, provided the treatment, and he had an experience of rapid reduction in his symptoms, something I've seen many, many times since, that Paul also experienced, and he'll tell you about a little bit later. And then from there, SGB has really been adopted into the military in special forces units, particularly where there's been a number of research studies that have really advanced the field from that time on. And so this is, just a summary of what I was talking about, that first case study that showed us the potential for SGB to treat trauma through Dr. Lipov's first patient there. A lot of times that's how innovation happens, is somebody is so desperately injured or ill that someone says, I've been thinking and reviewing the research and I have this theory, and, they say, I want it. If, you think it could help me and it's a minimally invasive, very safe procedure, let's try it. And so they did. And that was the case that started this whole field. And it's gone from there. So across the board, the range of positive outcomes for SGB is about 70 to 80% across different studies, different principal investigators and teams. That's the range. SGB showed clinically significant results in an RCT, that means randomized controlled trial. That was published in 2019 with several major military hospitals as the primary research site. Lynch and colleagues showed that SGB really targets the hyperarousal symptoms that I talked about earlier. That's really what appears to be the primary target of this medical intervention. It can actually improve reaction time and neurocognitive functioning. So it's called a block because that's what pain physicians do, is nerve blocks. But that's actually a bit of an unfortunate name because sometimes people think it blocks them in some way from, having emotions, like it numbs them out or something, or it prevents them from being able to respond to a real threat that might be in their environment. And neither of those beliefs are true. It's actually quite the opposite. It actually allows special forces operators to respond quickly, more quickly, improves their reaction time, and has allowed so many of my patients to experience a wider range of positive emotions, all the emotions, not just positive, but to be able to grieve and feel sad as well as to feel warm and loving feelings for others. So doesn't block us. Brian McLean is out at Tripler Army Medical Center in Hawaii. He's done thousands of these. He's one of the best in the field. He's on the active duty side. And he did a fairly sizable study of 250 soldiers, and 100% were satisfied and would recommend it to a friend. Similarly, Lynch and Mulvaney and colleagues showed that 95% of behavioral health providers who have used this, so they were informed, would recommend SGB. This was my patient X. I was at the VA at the time, and he asked me to get this for him. He contacted me 5 years after, and he said, I trusted you, but I didn't quite feel comfortable telling you at that time how dangerously suicidal I was, while we were meeting. And even though we hadn't talked about it, it was something I had discerned in him because we had that trust. And that's why I really took a risk and fought for him to have this in a system that wasn't doing it at the time. And I had a very brave friend who was a Harvard-trained anesthesiologist who had done this for pain, and he was medically qualified to do this in a safe and competent way. And this is what we did for him and a few other patients in the VA. So he said, this saved my life. And SGB gives people hope. I always like to show this one because after I had these experiences in the VA, it was very humbling because we would have these follow-up sessions, and I would have these moments where I would think, we've covered this point, or we've talked about this before, and I've shared these insights, but they didn't really take a hold. And now we're covering the same things again, and you're really hearing me now and realizing how much SGB can set the stage for people to really hear you in the room as a therapist, to really get calm in their own bodies and take in a whole new set of insights or apply what you've been trying to help them with for some time. So I had these experiences, and then I thought that was the end of it. One of my big volunteer positions is kind of an ongoing role as an associate producer of a Bay Area veterans television program. And someone said we should do an episode on Stellate Ganglion Block. So I actually came on with the VA provider that I worked with in the VA, and the two of us did a show and we were interviewed. And it had such a good outcome. I think one of our most viewed shows was about Stellate Ganglion Block. that I said, let's see if we can find the people who have really pioneered in this space. And I had 3 people on my list to call. Dr. Lipoff, of course, he was the first case report, and the first person who really developed a cohesive theory, a unifying theory as to why it works. And then there was Dr. Brian McLean there on the lower right, who is out at Tripler Army Medical Center. And Dr. Sean Mulvaney is a Navy SEAL who practices in Annapolis with Dr. Jim Lynch. The 2 of them have a practice together. And those are some of the most prolific SGB, people in the country, those 4. So I called Dr. Lipoff. He said yes, he would come on. I called Dr. McLean. He said yes. And we didn't need more than a couple guests. So I didn't meet Sean Mulvaney until many years later, or Jim Lynch. This was just Dr. Lipoff and Dr. McLean, and we had a great conversation. But I was really skeptical. I had seen this work, but you can see on my facial expression, clear as day, I'm like, really? You got to be like, let me push you on that a little bit. And so look at my expression on this slide and then compare it to what I'm about to show you on the next slide. This is how I look when I'm like, okay, I really see now that I need to radically collaborate with these physicians who are offering this procedure. It deepens, it enhances the work I do as a trauma therapist. It sets the stage for very different kinds of outcomes in therapy. And I was in Chicago, and this is before I worked for Stella. Dr. Lipoff had invited me to Chicago. I think it was before I worked for Stella. There was a few trips I took before I came on board just to treat people and just to be on Overwatch. So on this day, we had treated 10 of the veterans in my network that I had referred. And it was awesome to see them go through this transformation and to bring them through that together and be with them during this time. And Stella now has, it's like hard for me to keep this map even updated, has over 40 treatment sites across the nation. And we have also launched in Australia and will be coming in other countries as well in the next several months. So we have robust vetting programs to make sure we get the best doctors who really know how to do this. Typically, they've done this for pain. They have to show us that they know what they're doing in a practical way. And then they are provided with trauma-informed training that I helped write and develop. So they all receive that. And then we have our patient care team and our Stella ambassadors who are support to bring people in, answer questions, get them set up, give them follow-up to see how they're doing. All of it is kind of a comprehensive care model that we've been developing and building since 2020. One of the things that has been a barrier for stellate ganglion block is just how well it works. If I'm being just blunt and honest here, some people say that can't be true because it works so effectively. And, that was back to me in my skeptical days. I once was skeptical, and now I've seen it work with over 100 patients I know very well personally. In a study of 327 patients, so that's a big sample size, 83% of patients had a clinically significant outcome. That's at least a 10-point drop on the PCL, a widely used, validated symptom report measure of trauma symptoms. So 83% had a successful outcome, but the average result was actually 3 times what is considered a clinically successful outcome. So people can go from very severe symptoms to really experiencing dramatic relief, often in 1 or 2 visits to a clinic. And it doesn't really matter. We also found in that study what the cause of the trauma was. There were people with distal trauma, childhood traumas, for example, and more recent traumas, and both of them responded equally well. Stellate ganglion block can treat trauma because of a sexual assault or combat or the loss of a loved one in a traumatic way. So the results are kind of indiscriminate. It doesn't really matter what caused the trauma, SGB works, which to me is a really strong argument for the biological factor in this equation, that trauma causes a biological change. that can be healed with the right treatments. And so the new model that I've really been advocating for as a trauma psychologist is using biological treatments like stellate ganglion block and ketamine in combination with really good trauma-informed therapy, because it helps us overcome the mind state barrier. People I've seen often approach trauma therapy with fear instead of a sense of confidence and hope, because they don't have control of their own bodies. They feel out of control, so they feel like when they go into that office, one of the most common phrases I've heard from patients with trauma is, I don't want to open that whole can of worms, just over and over again, which is code for them saying, I don't want to feel all the awful, intense emotions in talking about and re-experiencing my trauma. And so often people will be in the office and fearful, and their brains are not operating in optimal ways. They might have difficulty, concentrating or be there, but not really be there. So to that point, you look at the kinds of symptoms people have when they have trauma. A lot of them are cognitive symptoms, problems with concentrating or thinking, problems with memory, confusion. They're not sleeping well. I mean, that has to make everything worse, right? It's all kind of biological. So if you can help people feel calm in their own bodies and feel that they, can think with clarity and concentrate, they will have a much better outcome. And so in this way, what I've really advocated for is to use SGB and ketamine and other biological treatments. I think psychedelics have potential, especially for certain applications, to accelerate and enhance the work of treatment providers using trauma-informed therapies. But therapy is still critical. This is not a magic cure, and we have to work on the thoughts, the behaviors, the identity shifts that are part of trauma. And so therapists are still critical to this process of healing. SGB opens a window of opportunity, but people still have to do the work to get a new normal and kind of maintain that gain. Paul Whitmer, over to you, sir.
Hey, Doc, thanks for having me.
Always.
Geez, where to begin? Every time I go through the slides, I just self-identify so much that it just overwhelms me sometimes. I received my SGB injection from Dr. Lipoff almost a year ago, March of 21. Symptom-free today and tomorrow, I anticipate. So we're pushing a year roughly since my injection. So I think it's important to note that this isn't something that's wears off in 2 weeks. I have been enjoying the benefits of the SGB now for almost a year. Primary benefits, immediate sense of calm, calm, but not a drugged state at all, just calm and visually able to see and interpret my surroundings and not look at them as potential sources of harm. It really sort of erased that hypervigilance mode that I had been in for some time. I'm an Army veteran, as Doc mentioned, 3 tours in Iraq, 2 tours in Afghanistan. I had returned and really had some difficulty sleeping. I think that was the initial thing that drove me in the direction of Stella. I went to grad school, did a graduate research paper on alternatives to CPT and PE, and I'm sure everyone's familiar with those terms. I did not have a singular intrusive memory issue, singular intrusive incident. I was a guy that came back and then thought everything was fine, and the next thing you know, I'm not sleeping, and now I'm frustrated, and now I'm hypervigilant, and it just was a domino effect in my relationship with my wife and my family and my friends. It really was impacting me. Wasn't a big guy on the drugs. The VA tried a few things. I tried them with them, and I didn't really get the results I wanted. I still, I didn't want to feel like I lost that edge. I wanted to stay alert. I wanted to stay, conscious of my environment. SGB did that for me. SGB, in addition to making me calm, it made me more patient. I became really, the frustration level just evaporated. I was really patient in traffic, which I'm sure a lot of you are used to. I'm patient at the store, in lines, and empathy. I think empathy is a good word too. I sort of felt what others feel, and I don't think pre-SGB I really felt that. I think I just was inside myself, and all the walls were up, and I really and I wasn't going anywhere. Other effects post SGB. So we've got the calm, we've got the, I feel patient, I feel empathy, a sense of empathy towards my fellow people that I interact with. I noticed a decrease in alcohol consumption. I don't know if this is typical of all. It's definitely something that I noticed. I was never a huge drinker. I didn't think alcohol was a real problem for me, but post SGB, I really didn't even consume alcohol. I think pre-SGB, I was using the alcohol to sort of instill a sense of calmness. And then post SGB, I didn't need that alcohol. So I won't say that's typical for everyone, but it's typical. It happened to me. The ability to receive effective therapy, I think that's a big one. I had some problems trying out CPT and PE, again, because I didn't have that singular intrusive memory. Post SGB, we went to a CETA, the Common Elements Treatment Approach, and we're having great success with that. So I think SGB, again, pushed those walls down that allowed me to interact with my provider on a much more effective level. You know, that mind state barrier that Doc mentioned, that's there. Post SGB, you know, I didn't have a name for it. I do now. And post SGB, I didn't have that barrier. And the accelerant effect. I'm able to hear what the provider's putting out. I'm able to let that enter my ears and go to my brain, and I'm able to work that, and it becomes so much more effective. When I think of the therapies that I went through pre-SGB, and I had the medications from the VA, and I'm trying CPT, or I'm trying PE, or something else, I just wasn't getting anywhere. SGB opened those doors for me, blew them wide open. I have a tremendous relationship with a therapist now, who may be present in the audience. He has done a lot of good things for me. And I don't think I would have that relationship or that level of trust had it not been for the SGB injection. Doc, I could talk forever on this. How far do you want me to go?
Oh, that's great, Paul. Let me do this. Let's allow everybody on here to talk. Here we come. What questions do any of you have for Paul or myself? And welcome aboard to those of you who are new on the PCC team.
I'll throw some more out there, Doc, while we're here in this,
Sure.
in the realm. Sure.
Yeah.
So following my deployments and following my return to CONUS, to the United States, and following my inability to sleep, and I ended up at the VA, and I ended up with 4 diagnoses at the VA: PTSD, TBI from some explosions that were very close to me, GAD, the generalized anxiety disorder, and MDD, the major depressive disorder. I honestly didn't think I qualified for any of those. When I was diagnosed, it was a surprise to me. I wasn't shopping for a diagnosis, but here they were. So if you've got clients or patients that are in that realm, SGB is kind of where we're at. Did I hear somebody with a question?
Question for you, Paul.
Go ahead.
One of the areas that people seem to be interested in is how does SGB work, if it does, for symptoms of depression and general anxiety. Have you noticed anything in your case on either of those?
Definitely. And I think that generalized anxiety can be pieced out into hypervigilance component, the frustration in dealing with others, interpersonal relationship issues. I think those can all be sort of lumped in there.
Yeah.
I didn't really, I got the diagnosis. It was on a piece of paper. I read it. I didn't really understand what it meant to have that. After SGB, I'll be honest with you, I feel pretty good. I returned from an Operation Mend visit in LA, and I was evaluated for PTSD by the folks at UCLA Med, and this is post SGB. And I did not qualify to rate significance to be deemed to fall. My scores did not fall within the realm of having PTSD. So I attribute this exclusively to SGB. I feel better. My interactions with my family and my wife are better. My friends, I mean, we go out, we do things, we have fun. It's no longer, stay at home and lock the doors and get anxious waiting for the mailman. Now we're kind of back to normal. So
that's amazing.
Level, yeah, tremendously.
How did the SGB work with the Operation Mend program specifically out at UCLA?
When I was at Operation Mend, I met a doctor named Howard, and you might have to help me with the last name, Doc.
The only one I know is Dr. Walter Dunn.
Walter Dunn. That's correct. Yes, Walter Dunn. And Dr. Dunn was extremely interested in SGB and how SGB had worked for me. And we basically had this same interaction that we're having today. I had this with Dr. Dunn, the one-on-one. And he's very interested in my results. I think he had obviously done his research and he knew about SGB. It wasn't something out of the blue. But following my evaluation at Operation Mend with Dr. Dunn and his staff, the PCL did not reveal, I wasn't high enough on the PCL to even rate PTSD. So that was a shocker. I mean, if that doesn't tell you something right away, I mean, and I have several friends, military friends that have received SGB injections. I've interacted with a lot of them before SGB, and I've interacted with them after SGB. And we're batting 1,000. We have yet to have someone, I have yet to personally know someone who has received the SGB and not been positively affected by it.
And you put me in contact with Dr. Dunn. That's how I met him initially, because he had that interaction with you. You didn't even have symptoms of PTS enough to be interesting to a psychiatrist, right? In terms of symptom severity, you put us in touch and you said, I think, it'd be great if Stella and Operation Mend could treat people collaboratively. What was the basis for that view, and what do you think the potential is there for a co-treatment model?
Well, the folks at Operation Mend are a great group. Boy, they are a dedicated group of professionals. Dr. Joe and her team go out of their way to bring veterans who have been affected by TBI and PTSD to UCLA Med Center. For instance, they flew me to UCLA. And I had a daily schedule of interactions with different teams, behavioral health teams. I had an MRI of my brain, which I doubt I could ever get through the VA system. I don't think I could ever get that. So the folks at Operation Mend provided a level of care that exceeded what is normally available to most veterans.
Mm-hmm. Cool. And how do you think deploying the SGB before doing that program could make a difference, if you think it could?
Oh, definitely. When you enter a doctor's office, for example, and you interact with be it a behavioral health clinician or even a medical doctor, I mean, if you've got those hyperarousal symptoms and the walls are up, I mean, you are denying them the input they need to make critical decisions in your treatment and your care. So by having those walls down and being able to, calmly discuss, here's how I'm feeling. Like you said, a lot of people don't want to talk about it. They just don't want to talk about what happened, what brought on this trauma. I was at a place where I didn't know what brought on the trauma. I had no singular intrusive memory. So I was really at a loss. I couldn't have remembered it if I had to. But the SGB allowed us to, again, I'll say it again, knock those walls down. And it made it so that I could converse with my clinicians and effectively communicate with them. And then they structured their care accordingly. So I think it would have been extremely hard for both myself and the clinician to do pre-SGB. I just think it would have been extremely hard.
Yeah, I've heard that from a lot of patients. And my hope is that, clinicians like myself will see the bigger picture of what is the most effective, most compassionate way. Not is what we're doing now working well enough, but how can we continue to improve to support our veterans to get the best care possible? For me, that required some measure of humility to say, just because I offer it and I know it can help, does it mean it's the optimal way to set people up for success? And so my hope is that, field leading physician teams and psychologists and treatment providers could radically collaborate and really change this for so many of those who suffer across the country. I know I've heard really good things about Operation Mend as well from a number of patients I've referred there. And I think that would be amazing to partner with them. So we'll see, I'm going to explore those conversations in the months that come and follow up on any interest that might be there. And I'm grateful to you for introing me to Dr. Dunn.
Oh, my pleasure. It was so neat to see his eyes light up when I mentioned SGB. I said, hey, I had SGB before I came here. And he was like, whoa, SGB, let's talk about that. And everything else kind of took a backseat. All the checklists got slid to the left. And then we just talked about SGB. Again, it's not, and you said it perfectly, it's not the silver bullet. It's not the one and done. It's the get it done. And now it allows the other protocols to really become effective beyond what they could have ever been. I think I see a question from Teresa.
Okay.
One of the CCs. Do you see it on your end?
I do. Hi there. Thank you for sharing your story. That one's to you. I wanted to ask a little more about potential side effects. I understand there are some rare risks with the procedure, side effects right after the procedure, but in the long-term side effects that have been documented or shared? Or is it primarily just about the range of how effective it is at decreasing PTSI symptoms? Well, I can take that on because I'm kind of steeped in the research.
Sure.
There isn't any documentation of any serious long-term side effects. The kinds of side effects that, we look out for by picking the best doctors and training them and vetting them are the kind of things that you'd find out pretty quickly, if they happened and want to make an intervention very quickly. In terms of long-term side effects, the way to answer that. So a lot of people are kind of skeptical by nature, which is helpful, but it can also limit innovation. And they tend to think it can't be this good. It can't be, it must be too good to be true. But remember, this is an anesthetic medication. So how many people getting surgery receive anesthesia every single day? How many women giving birth to children receive anesthesia every day? How many people get Novocaine when they go to the dentist every single day? So the injection of anesthesia into a localized place in the body that does not go up to the brain, that is reabsorbed, and it's just an anesthetic medication that the FDA has approved for anesthesia and pain-related procedures, does not have long-term side effects that have been documented in the literature. And if it did, we would know if there was a preponderance of evidence at this point. There was one study done in 1992 by Wolf that had 40,000 people who got the SGB for pain, not for trauma. And the incidence of side effects was very low, and they were things that would surface right away. So if you had somebody like me that has no training saying, oh, I'm going to pick up that needle and see what I can do, then you might inject it in the wrong place. And if you inject it in the wrong place, you could cause something like seizures or, some kind of maybe paralysis or something if you put it in the wrong place. But with a qualified physician who is well trained in using visualizing techniques like ultrasound, or that's probably the best one from what I hear, or fluoroscopy is not quite as detailed because it doesn't let you see the veins. If you have a good physician who does it correctly, there really shouldn't be any long-term side effects. So I just kind of put it in the same category as people saying, well, what are the long-term side effects of getting anesthesia for this surgery or for getting an epidural for your childbirth? The answer is there shouldn't be any if it's done right.
I can add to that if I could, Doc, I could address the side effects right after the procedure, as
Sure.
you could as well. I had some, of course, it was a guided procedure, right side. I elected not to go with the twilight sedation, so I was fully alert and conscious throughout the entire procedure. The procedure was fairly brief. I want to say less than 10 minutes. And I was fully conscious and alert the entire time. Now, it's not like getting a flu shot, I'll tell you that. There's a little bit more involved. There's some guiding, so there's some maneuvering, and Dr. Lipov, I mean, he's the king. But I had some, so post SGB, I had a really sort of a scratchy throat, and my voice box was a little affected. I had a little bit of difficulty talking clearly. I had some droopiness on the right side of my face, and my right eye was reddened. Those effects lasted, I came home from Chicago. I went to bed that evening and had my first night of 8 hours plus of uninterrupted sleep, fell asleep with a book on my chest and woke up and it was still on my chest, which hasn't happened in 10 years or more. And I pretty much had all the symptoms had been alleviated. I still had a little bit of a scratchiness in the throat, ice water. That was gone by probably noon the next day. Doc, I don't know if your symptoms are similar to that, but I can tell you, I was very pleased with my results. I didn't really feel impacted negatively.
What you're talking about is called Horner's syndrome, has a name, and it's actually something that we look for. That's good. And so Paul is referring to the fact that I also had a stellate ganglion block, and they will go away, those symptoms that you mentioned, within 24 hours, sometimes within 6 or 8 hours. But if you go to sleep and you wake up the next day, you will not still have a droopy face. It's a temporary effect, and not so much a side effect as what we call an expected effect that we're actually looking for and hoping to see to show that the injection has been placed correctly. So we hope that you'll have a droopy eye and some of those symptoms, and they will go away within 24 hours. This is great. I mean, I didn't plan this conversation. As you know, Paul, we're just sort of here talking about questions, but I I'm glad that we did kind of have this conversation today about this and the potential that's there when we can radically collaborate with really good teams of providers. So
Yeah, I agree. Spread the word. I mean, this is such a neat, in essence, we get away from the meds and we get away from it's quick, and it sounds too good to be true. And I think you said that earlier in your presentation, and I think you were one at one time that said, well, this sounds too good to be true. And
because we're natural skeptics in my field. You don't go to school for too long, I'll just put it that way, to not be sort of careful and skeptical. It's how we're socialized, especially as trauma providers. We're protective of our patients, and we, are in school for a very long time, and we're naturally skeptical. But seeing this work for over 100 patients and counting has been amazing. Echo, stop. That's my Alexa. Echo, stop. Keeps me on track. Let me tell you.
Go ahead, Doc. Sorry.
I want to tell you who we have coming up next, though. So one of the next media stories that we have coming out is actually Kevin Briggs, and he is an Army veteran. He's also a former California Highway Patrol, and he patrolled the Golden Gate Bridge and has personally stopped or saved over 200 people from taking their lives by jumping off the Golden Gate Bridge. And so Kevin and I went into the clinic about a week ago here in San Jose. He got treated. He asked me to film and document it, and we're going to be worked on a radio presentation at Warm 106.9 that'll be going out, I think, on Friday and Sunday of this coming week. So fellow Army veteran, amazing man. I'm going to bring him on the podcast, and we'll track his progress. Any last words, Paul?
No, I just think that if people would explore this, I mean, again, I explored this years before I got my SGB injection. I knew about SGB. I had read the likes of Mulvaney and Lynch and McLean and Lipoff and Olmsted, who was on last month with us. And so I knew what I was getting into. I didn't know that it was available to me once I left the military. And so if there was a line, I was going to be first. So I knew what I was getting into and came in gratefully. So thank you very much for your time.
Next time I'll wear that special pin you gave me from your unit. All right, I'll have a great day. Thanks, Paul.